In this video, we will review high-yield cardiovascular concepts through 5 clinically relevant cases commonly tested on the USMLE Step 1. These cases integrate key principles of hemodynamics, vascular anatomy, cardiac physiology, and pharmacology. We will explore how changes in vessel radius affect blood flow, the clinical implications of renal vein compression, pressure changes seen in valvular heart disease, essential landmarks for vascular access, and the mechanisms behind common cardiac medications and their toxicities. The goal of this video is to help you connect physiology with clinical scenarios, making complex concepts easier to understand, retain, and apply during your exam. Case 1. A 63-year-old man with long-standing hypertension undergoes a CT scan of the lumbar spine, which incidentally reveals a small right kidney. Angiography demonstrates atherosclerotic narrowing of the right renal artery, while the left renal artery remains intact. Blood flow in the right renal artery is decreased by a factor of 16 compared to the left. The question is, by what percentage has the radius of the lumen been reduced? The correct answer is 50%. Blood flow through a vessel is determined by the pressure gradient divided by the resistance to flow. According to Poiseuille's equation, resistance is inversely proportional to the fourth power of the vessel radius. This means that even a small decrease in radius produces a large increase in resistance and a significant decrease in flow. In this patient, flow is reduced by a factor of 16. Assuming all other variables remain constant, this corresponds to the radius being reduced to 1/2 of its original size. Therefore, the lumen radius has decreased by 50%. Case 2. A 20-year-old man presents with hematuria and intermittent left flank pain for several months. Urinalysis shows 3+ blood, with no white blood cells, crystals, or organisms. A CT scan reveals no abnormalities in the kidneys or ureters, but shows compression of the left renal vein between the superior mesenteric artery and the aorta. The question is, what vascular abnormality is most likely to develop in this patient? The correct answer is varicocele. Anatomically, the right renal vein is short and drains directly into the inferior vena cava. The right gonadal vein also drains directly into the inferior vena cava. In contrast, the left renal vein is longer and passes between the aorta and the superior mesenteric artery before draining into the inferior vena cava. The left gonadal vein drains into the left renal vein. Compression of the left renal vein between the aorta and the superior mesenteric artery increases venous pressure. This is known as the nutcracker effect. Persistent elevation of pressure can lead to left renal vein entrapment syndrome, causing flank pain and hematuria. Increased pressure is transmitted to the left gonadal vein, leading to valvular failure and dilation of the pampiniform plexus. This results in a varicocele, most commonly on the left side. Case 3. A 50-year-old man presents with exertional dyspnea and fatigue. He also reports difficulty breathing at night and requires multiple pillows to sleep. He has occasional palpitations but no chest pain. He undergoes left heart catheterization, which shows pressure changes consistent with mitral regurgitation. During the cardiac cycle, the left atrium fills passively with blood from the pulmonary veins during atrial diastole, which occurs simultaneously with left ventricular systole. In a normal heart, left atrial pressure gradually increases to about 10 mm of mercury, forming a characteristic V wave at the end of passive filling. In mitral regurgitation, the mitral valve is incompetent, allowing blood to flow backward from the left ventricle into the left atrium during systole. This causes a marked increase in left atrial pressure during ventricular contraction. As a result, there is an early and prominent V wave on the pressure tracing, which is the characteristic finding in mitral regurgitation.